And good afternoon, everybody. Welcome back to our bi-weekly webinars about some challenging surgical cases that we have encountered in Gaza. I've had so many great inputs from all people all over the world, indicating the importance of such webinars to continue. The local people of Gaza are learning a lot from trauma surgeons, giving inputs from all over the world for these difficult and challenging cases. I'm going to go quickly with how did we end up starting these webinars. That was back in January of last year, actually, when we did the first webinar. We had a plan with Dr. Ghassan Abu Sitti at that time. He could not make it. We had Tanya from Chicago. And then Khalid Al-Sir, he was a surgeon in Nasser Hospital in Gaza. He got in and we were basically we saw some challenging cases that he encountered at that time by himself, being a freshly graduated surgeon. So this work that we started resulted in multi-paper, basically research projects about telemedicine in war. So basically, we created WhatsApp groups, Telegram groups, and we started to support the local people of Gaza, the local surgeon of Gaza, going through challenging cases with very, very limited resources. And as you can see, we had this published in the Lancet and has been presented also at the American College of Surgeons. This is Khalid. Again, had the honor to go and serve back in February and March. And we presented some challenging cases during this webinar. And based on that, Ali from United States and Hani from Oman, both trauma surgeons, Hani ended up visiting with me again in Gaza. So after we finished the second trip in Gaza, we presented these challenging cases. And we had people from Australia, from USA, from everywhere tuning with us, discussing these challenging cases. Then we concentrated on hepatobiliary injuries, people from Australia, from USA, and it was a very good, basically, webinar. Dr. Matrix at that time gave us a very great input about these challenging hepatobiliary injuries. And then we had the honor to meet with Dr. Run, who's a surgeon and was kidnapped and detained by the Israeli army while he was on duty in Al-Ma'madani Hospital, or the Baptist Hospital. We had his as an eyewitness about what he had encountered. And then Khalid Sir himself was arrested and also was released. And also we had the honor to meet with him as an eyewitness of what he encountered as a surgeon, was taking care of his patient and was detained from his place. And all these webinars, for people who are joining us for the first time, you can find them in this YouTube channel. It's my YouTube channel that we've been documenting all these webinars for future references. We had a very interesting webinar last 2 weeks ago by Dr. Matrix about duodenal injuries, and we had received so many great inputs, Dr. Matrix, about all your basically suggestions and teaching points about duodenal injuries and challenging cases we encountered in Gaza. So this is just a brief. This is the WHO health cluster report from January 14. You can see all this area in the red are active area of basically military targets, and you can see there's only few places in the white that are the safe humanitarian zones. At that time, January 14, this is before the ceasefire, we had 46,600 casualties, and you can see basically the rest of the numbers. After the ceasefire was signed, this is from January 22nd, we had the casualties increased around 600, 47,000, with 111 people injured. And you can see the area that is white now, it's a safe humanitarian area. And the area that is basically pink or colored is the active military area. Nobody can reach there. And at this time, what we're talking about, people are in the south trying to go back in the north, which is at this time, it's not allowed. This is again a webinar. Today, we would like to welcome our distinguished panelists and speakers. I'll start with Dr. Dimitrios Dimitriadis. He's the professor of surgery in Los Angeles. He's a pioneer in trauma surgery. We thank Dr. Matrix about the introduction and the connections. Dr. Dimitriadis is a pioneer and a legend in trauma surgery. He had published several trauma atlas, colored atlas for trauma, emergency trauma cases, as well as critical care cases, books. So basically, it's a great books that we have used so many times in our training, and we still refer to them every while and then for our emergency trauma cases. And then we had our speakers today, Dr. Tariq Al-Haloul. Tariq is a thoracic surgery fellow. He did not finish his thoracic surgery training, but he was the only thoracic surgery service to the north of Gaza. So the whole north of Gaza, around 400 to 500,000 of people, with active military targets over the last 15 months, he was the only guy to provide thoracic surgery services. I had visited Tariq at Gaza City right there and saw how great work he did over the last basically 15 months. And I believe he's, from my standpoint, the kind of cases that he's done, the kind of service that he provided goes beyond any thoracic surgeon that I've met and worked with. And then we have Dr. Riyad Abdul Jalil. He's a thoracic surgeon, worked at the Cancer Center in Jordan, King Hussein Cancer Center. He's trained at both Mayo Clinic and Cleveland Clinic. And he also had the honor to visit Gaza twice, early February last year, where he worked at the south of Gaza, and just returned back from Gaza a month ago, where he worked at the north of Gaza for 2 weeks. And finally, my friend, Jordanian friend, Zaid Abdel Sattar, he's a consultant thoracic surgeon at Mayo Clinic, where he does a lot of complex thoracic transplant and robotic thoracic surgery. Thank you so much again, everyone. And just when we talk about thoracic surgery in Gaza, there's only one thoracic surgeon for the whole area. His name is Dr. Raed Al-Araini. He is right there performing a thoracic surgery injuries in a patient without gowns and without surgical gauzes. And I'll leave you with this video for him.
Lung injury, diaphragmatic injury, splenic injury, chest wall, severe injury. We haven't abdominal gauze. We haven't any scrubbing. We haven't any gowns here in the Shuhada Al-Aqsa. Today we haven't anything to go and to help our injuries with Dr. Victoria from New York, our colleague here with us, but we lost daily our patients daily. We haven't.
So again, we had encountered the same situation in Gaza where we operate without surgical gauzes. And it's irony to know that according to the Encyclopedia Britannica, that the gauze, which is a light open weave fabric made of cotton when used for surgical dressings, and of silk and other fibers when used for dress, the name is derived from that of the Palestinian city of Gaza. So it's really an irony to know that the gauze that we use for our surgical procedures, originally the name related to Gaza, and Gaza had no surgical gauzes. At least I have witnessed this thing myself, and I will see if Tariq and Riyad can confirm this, as well as this is a video from Dr. Raed Al-Araini, who's the only thoracic surgeon, board certified thoracic surgeon in Gaza. He works at the south, and Tariq works at the north. So Tariq, can you start your case, please?
Yes, thank you all for this meeting. My name is Dr. Tariq Al-Haloul. I am a thoracic surgeon fellow in Shifa Hospital in North Gaza. This case now for 27 years old male patient who have a history of explosive injury with the shrapnels penetrating his neck from the lateral side without exit. Now the injury was in North Gaza. At that time it was a red zone. No one can go to these hospitals. All the surgical specialties are outside this red zone area. So the patient have esophageal injury, which after that start to do fistula with the right chest.
Tariq, just to summarize, so 27-year-old shrapnels injury to the neck. You did not see this patient on arrival, is that right? This is something you're providing us?
No, the patient presented after 25 days to me.
Okay, so he presented to you at the thoracic surgery service after 25 days. Do you have more details about the presentation that he had? Was he Was his ABCs intact? What was his vital signs when he presented? I see the injury you report back in November 5th. That was
Yes, of course. And at that time, the patient was not stable. Our colleague there in the ER, they put two chest tube
Which
on
hospital
the
he
right and the
presented?
left side.
Which hospital he presented?
In Kamal Adwan, in Kamal Adwan Hospital.
So Kamal Adwan Hospital, which is right there, it's the most north part of the city, and that was when Kamal Adwan was under siege. Is that right?
Yes, under siege and under fire and under bombing from the military. And there is no services there at all.
And there is no surgeon. There were only pediatrician there, Dr. Hussam Abu Safiye, who later was arrested by the Israeli army. Is that right?
Yes, that's right.
So he was taken care by general practitioners and pediatricians when he arrived back in November 5th.
Yes.
Okay, but you don't
now. Now the patient, two chest tube inserted on the right and the left side, and the main complaint for the patient that he was not able to eat, and if he eating, the food start come out from the chest tube. So at that time, they contact me and I advised to put him in the TBN, but unfortunately there is no TBN available in North Gaza at that time. So he only was in Rosukin IV.
One second. Dr. Dimitriadis, do you have any comment here?
So, good morning again to all. I wanted to say that the patient survived 3 weeks after the injury because the esophageal injury was very high at the C8 level.
Okay.
Remember that the esophagus starts at the C6. At the C6 level, above the C6, it's pharynx.
Okay.
So normally, if it had been a little bit lower, the patient would have died very quickly of uncontrollable mediastinitis. He made it because it's a very high injury still in the neck, no significant extension in the mediastinum. Thank you.
Very nice. Dr. Riyad Zaid, do you want to comment here?
Yeah, thank you for the presentation. Thank you for the meeting. And I think there is some communication between the neck and the chest, because the chest tube was bringing some food and some clear fluids when he was eating. Usually, as Dr. Demetrius said, it's easier to manage the injury in the neck part rather than in the chest part. But in this patient, and what causes the sequences, Dr. Tariq will tell us about him now, that he has some communication in the injury between the neck and the chest, and that was complicated things. And there's no supply to help, or nothing actually. There's no supply to help in North Gaza. So yeah, he survived three weeks because they drained it very well. But then things, I think, would go crazy after that, right, Tariq?
But Dr. Dimitrius was clear enough that we would not have mediastinitis that would kill this patient. He might have empyema, but the mediastinum is not an issue here. Is this correct?
Sure. Yes, sure.
So I think that's the point, is that no mediastinitis, which we think would be very difficult to treat and very difficult to manage. Okay, go ahead, Tariq.
After 20 days, the patient referred to Gaza City by ICRC.
Which is the International Red Cross. Is that right?
Yes, of course. Yeah. At that time, I received the patient in Al-Ahli Arabi Hospital. He was in very septic general condition. He was feverish, hypotensive. Blood pressure was 80/50. Now both chest tube are draining pus and food. Immediately, I do resuscitation for the patient and admit him for a hospital. After stabilization, we did CT with him for oral swallow and IV contrast. And actually, there was a posterior mediastinal abscess, a huge abscess, with bilateral empyema and a contrast leak from the esophagus at the level of T8 and T1.
Okay, Zaid,
so
you are just one second, Tariq. So Zaid, he's also joining us from California. He's at the thoracic surgery meeting, and he's a thoracic surgeon at Mayo Clinic. So Zaid, if this patient comes to you at Mayo Clinic, how would you manage this patient?
Thank you so much, Osama. I mean, I can't imagine the conditions that you guys have been practicing in. This is, beyond what a normal mind can handle. But yeah, this is an extremely difficult case. I mean, the fact that he's made it for 3 weeks with an esophageal perforation for this long is impressive. So for something like this, you need at least to start with wide drainage. Any area that has pus that needs to be drained out. You need to optimize their nutrition as much as possible. It's hard when you have an esophageal perforation to optimize nutrition, so you have to find alternate GI access or start on the TPN. And I can imagine that most likely these two things are not going to be possible. So, from the start here, would start with wide drainage as much as possible.
Dr. Dimitriadis, can you give us some inputs here, please?
About
Yes,
the TPN, possible, but when he arrived to
Yeah, I agree with the comments. At this stage, there is absolutely no role of reconstruction. I would do a proximal esophagostomy and wide drainage and wait, improve the nutrition, and under better situations, I will do the definitive reconstruction. At this level, it's very difficult to put an esophageal stent. A stent will be a better option in lower esophageal injuries. At this level, you might try, but it's not likely that will succeed.
Okay.
Thank you.
Okay, just to let you know that GI gastroenterologists are not available in the north, neither esophageal stents. And Tariq will tell us, what did you do, Tariq, for this patient?
now, when the patient after the CT, I consult our GI surgeon here, Dr. Hazim Al-Haddad, and our ENT consultant, Dr. Ahmed Al-Rabi'i. And unfortunately, there is nothing to be done for him except for referral outside Gaza. So the patient general conditions start to deteriorate more, and I have to decide to do bilateral decortication and to drain at least the posterior mediastinal abscess. And that's what I did. I did bilateral decortication on the same session with drainage of the posterior mediastinal abscess, and 2 cystic tube was inserted. Now, this is the CT with the posterior mediastinal abscess. Unfortunately, I don't have video for him, just cuts.
So this is the CT right there. This is the posterior mediastinal abscess. Okay, Riyadh, how do you approach this patient with bilateral thoracotomies, or would you do, clamshell anterior thoracotomies? What's your incision would be Riyadh in such approach?
So basically we need to drain him both sides. We found that we have some VATS instruments in Gaza, in northern Gaza, and it was working. So maybe I will try to drain it with VATS and both sides, and then both chest tubes, because bilateral thoracotomy on a sick patient is a big burden, and he will be very more sick, because when you drain or decorticate, the patient will get sicker before he get better. So I will perform VATS on both sides, or maybe on 2 days sequence if I do thoracotomy maybe. But this is what they have. So I don't think they did wrong, because they need to drain the abscess. The abscess is causing a lot of troubles.
So, Dr. Dimitriadis, what's your experience with bilateral thoracotomies on the same patient, sick patients? Would you avoid this by doing just an anterior, clamshell incision?
I would not do a clamshell incision, but because it's a very high mediastinal abscess, very often you're able to drain it through the neck and avoid the thoracotomy. On the CT scan, I did not see any pleural effusions. It seems that the abscess was localized in the upper mediastinum. Am I correct?
Tarek?
There is another cut of CT below. If you can go, you will see. I put 2 slides for the before operation and after.
Yeah.
If you can go lower.
So this is the only slide that I received from you. Maybe it got missed somehow. But definitely when you opened him, you had pleural abscess and pleural empyema.
Yeah, it's very, very, very aggressive empyema on both sides. I mean, the problem is the left side is worse than the right side was.
Okay.
That's what I have to decide to do bilateral thoracotomy in the same decision.
Okay, but have you thought
But there is
about
another.
doing a trans-cervical drainage of the mediastinum? Have you thought about this, doing a trans-cervical through the neck?
It's not in my expertise actually. Yani. I even consult our general surgery to help me. They refuse. Yani. They told me don't touch the patient eventually. Eventually they decide he will die.
Oh, let's just remember that Tariq is still a thoracic surgery fellow. He's still in training. So, again, tell us what happened, Tariq, next.
There is no, you can go down with the slides. There are no cuts for CTs or any pictures.
This is the picture that I received from you. Can you explain this
Go
picture?
down. This is the what I'm pointing for, the posterior mediastinal abscess. We will drain it.
Right.
Yes, at this time.
Okay.
Yeah.
Okay.
Now, can you go another slide? Another
Now,
slide. Another one.
Another one. Yeah,
There
this is
two
before and
CTs
after.
down. Here. Now this is the CT before and after.
Yeah,
On the right side before and on the left side after.
okay.
Now, if you go another slide down, you will see the empyema in the left side, also worse.
Yeah, I see right there.
Another slide down. Okay, this one here.
Yeah. Okay, yeah, yeah, exactly. So, Dr. Riyad, any comment here?
Yeah, I think they did what they had to do. On my side, I said that I would prefer to try the neck first and try percutaneous drainage of this collection in the left pleural cavity.
Yeah.
Having in mind that the patient is very malnourished and having in mind that the abscess, the empyema on the left side seems quite localized. It's a chronic empyema now, and at some stage it's going to need decortication, but perhaps I would consider this later on if the percutaneous drainage fails under better circumstances.
So, Zaid, what do you think about just doing a control with percutaneous drainage and do the decortication later? Again, there's no interventional radiology available. And what do you think about this approach in general?
Yeah, I mean that's possible. So when you have an empyema, there's two, things that you have to deal with. A is the sepsis. You have pleural sepsis, so you need to control that. And the general saying, this principle applies to anything in surgery. If there is pus about, drain it out. So on in that CT scan, I would make sure that there's a chest tube on the left side. And then given that this has been 3 weeks old, so there's probably going to be a stage 3 empyema, then you'll have a rind on the lung. So that lung is probably not going to expand. But we can deal with the expansion problem and the trapped lung later. So, one thing to do is temporize this patient, get the sepsis out with a cervical incision, drain what you can from above, make sure that you have wide drainage. Also, if you can, since it's a cervical injury to begin with, you can keep that open, pack it in the neck, and then do a left chest tube. The right side, you guys did what you had to do, obviously, and there's absolutely nothing wrong with what you did. It's a very appropriate way of managing this patient.
This is again, it's nothing about wrong or right. We're trying to learn. This is something
but I mean,
educational event about what is the best approach for such cases, knowing that we have so many trainees with us. We have 90 people on board with us right now. And they want to learn. I think temporizing it with controlling of sepsis is an option by draining the cervix, draining the chest, and then do the esophageal, maybe esophagostomy, and maybe considering doing some sort of gastrostomy tube. Nobody had mentioned that. Dr.
Yes, I was just going to mention. So, I mean, and also this right side, I think that's where that chest tube was to begin with. So it looks like it's drained. So that right side, probably you can go away without doing anything for it for the time being. I think most of this patient's sickness is from the pus that's there, and that's in the mediastinum and on the left side. And then for any decortication, honestly, for any patient that you do a major operation on, you have to make sure that they have enough nitrogen in their body to heal, right? They need protein, they need as much nutrition. So this patient for sure needs some form of feeding access. Now, if you're in the OR, you already drained the neck, you already drained the chest. I would see if we can do, a G tube. If there's GI, you can do a PEG. Again, you can also see the hole in the esophagus. You can see it where it is if you have an endoscopy at the same time, and you can actually be close to where it is in the neck, you can make sure you pack that area, keep it widely drained.
Okay, Tariq, please, can you finish? Can you continue?
Okay, now after I did bilateral decortication and range of posterior abdominal abscess, the patient admitted to the ICU for 2 days. First day was intubated the first 24 hours. After 24 hours, he was extubated. He was very well. His CBC WC count dropped from 30,000 to 8,000. I put him in broad-spectrum antibiotic, including Marinum and Vancomycin. Patient discharged from ICU after 2 days to the male wards. After that, I arranged with the general surgery to put a gastrostomy tube for him. This is the only thing that we can do in Gaza. There is no big tube. There is no endoscopy. There is no interventional radiology. There's nothing. I did what I can with the means that I have.
Okay.
Now,
just 1 second,
yeah.
Tariq. Dr. Dimitriadis, do you have a comment, please?
At the first operation, what happened to the esophageal leak? Did you find a perforation, or just the patient was scared, he was discharged with an esophageal leak?
Tariq?
Now, the esophageal injury was very high. I couldn't handle it from the chest, actually.
So you did not do anything for the neck?
After
you did not do anything
I cannot
for the
handle
neck?
It's from the neck, no. For my expertise, I cannot do anything. And I consult another, they refuse to take the case.
Okay.
So I stuck with the patient.
Okay.
So
Now,
when the patient was discharged, the food was still coming through the neck. What was the situation?
He was discharged on controlled vacuum drainage for the esophageal fistula. There is still pus coming from the neck to the chest. There is esophageal pleural fistula.
Okay. Riyadh, do you have a comment?
Yeah.
Yes, Riyadh, we need to hear you. Unmute yourself, Riyadh. Okay, Dr. Dimitriadis, do you want to comment here? This is a controlled esophageal pleural.
I'm sorry, I was talking with the mute.
Okay.
So, sorry. Yeah, actually, I think Tariq mentioned that he was still eating. Like
Yes.
he has like almost started to heal and he's still eating. So I think that was contributing to a non-healing fistula. Maybe if he just stuck to the gastrostomy feeding, but maybe there's no ensure or any kind of, right, Tariq?
So this is
Yes,
not this is an esophageal pleural cutaneous fistula. This is not an esophageal
Yeah.
fistula.
True.
Interesting. Dr. Dimitriadis, any comment here?
Yeah, I agree. The patient would have benefited from a gastrostomy at the first operation. Keep him not to eat anything and feed him through a gastrostomy to, number one, to reduce the output from the esophageal fistula, and number two, to improve the nutritional condition of the patient.
But just started to talk about draining esophageal injury through the neck. I believe, that's something any thoracic surgeon should be able to do. I know you're still in your training, but Riyadh, when you guys do esophagectomies, Zaid, when you guys do esophagectomies, you guys train your fellows how to get the esophagus out of the neck, and even with any neck dissection. Is this correct?
True. Yeah.
Yes, absolutely.
So I think just a wide neck incision, getting the the carotid as well as the vessels away, you will find the esophagus in the back of the neck right there. Dr. Dimitri, any tricks here, Dr. Dimitriadis?
So I agree with you. Just for the trainees, as I mentioned earlier, the esophagus starts at the C6 level. The C6 level is the cricoid cartilage. So I think through the neck you'll be able to drain the abscess there, the mediastinum. You might want to consider doing a diverting proximal esophagostomy, bring the esophagus out. But again, this is in a very well-controlled environment.
Okay.
It's very different. It's a very different situation if you are in Gaza and do not have anything to work with. Thank you.
Dr. Mattox, you want to comment here about neck dissections for the esophagus?
Yes, Dr. Demetriades and I see pretty much eye to eye. While he was in northern Gaza, you only had a pediatrician, or did you have anyone with any surgical skill?
They have some general surgeons, just general surgeons, but no thoracic surgery. But the patient, when he presented early,
number one.
Yes.
Okay. I would not do any esophagectomy. I would want to preserve all the esophagus I had, and I would early do a lateral esophageal fistula, but you already had that from the wound. So and I would not want to feed him. So the first operation I would do on him is a feeding gastrostomy or a feeding jejunostomy, and you could use if you have blenders, you could make food from whatever food you have and begin to feed him. Number two, once he was seen by the thoracic surgeon, we have in the right chest that loculated empyema. Getting a chest tube in that is possible, but also doing an Eloiser flap. Eloiser flap is removing a small portion of rib and suturing the pleura to the skin, or creating a fistula that goes to the abscess. So I would stay out of the deep mediastinum, the deep chest, and I would want the neck to heal, everything except the fistula, and I would feed him through the abdomen.
Zaid and Riyadh both are experienced thoracic surgeons. Have you ever done this flap before?
Yeah, we do LOSers, for multiple reasons. It's the problem is with an LOSer, you need to pack it with gauze, and there's no gauze. So what are you going to pack with for this LOSer? So the whole idea of an LOSer is now you have an open thoracostomy, right? So you have an opening where you can pack things, you get packing, you only do micro debridement, you don't have any pus under pressure. So all that stuff just drains out through the marsupialized skin on the pleura. It's a great option. It's a great bailout option for ongoing sepsis. But I think, it seemed like his sepsis got better. Now the problem is we don't have source control of the hole.
Go ahead.
And no nutrition yet.
Go ahead, Tariq. 1 month later.
Now, 1 month later, the patient presented to ER with dyspnea and fever. On examination, he was pallor, feverish. His oxygen saturation on room air was 60. History of eating food, meats. Actually, in Gaza here, we didn't see chicken and meats for 1 year. And after last month, now they allow meat to come to Gaza. I think the patient become weaker and start to eat. Now, after 9 days from eating, he have another attack of mediastinitis and right upper lobe abscess, which was very big abscess, and even the abscess rupture inside the chest cavity.
So just to summarize here, Tariq. So you send him home with a gastrostomy tube to eat, and you advised him not to eat anything by mouth, and you had this controlled esophageal pleural cutaneous fistula for the chest wound on the left. Is that right?
On the right side.
On the right side. So patient has food for the first time, like meat for the first time. He could not resist. So he went ahead and ate meat, and 9 days later, he presented septic with this kind of CT scan. Riyadh, what do you think?
So yeah, I think the process of infection didn't resolve completely, but because he's young, no morbidities, strong guy, he was just with no a lot of symptoms or nothing to bring him to the house or to the hospital, but to reach infection to destruct the lung, I don't think this is just 1 week. It was the whole time. And when you have such an infection to destruct the lung, I think this is a very late stage. And as Tariq said, he couldn't just resist, and he started to eat when he found the food. So it's just, as Dr. Quinn said, it was just the appropriate thing is just to do the stoma. So you divert everything, and you then will control the sepsis. But with this, I think it was ongoing process, but he came to the hospital when he was very sick.
Zaid, do you want to comment about this lung CT scan and this bad abscess?
Yeah, I mean, this CT scan, I think an LOSer would be the appropriate thing to do for this image, you know. Plus, you need to have source control. And we always have to remember, even if he's not eating, the human being makes about 1 liter of saliva a day. And it goes down from the mouth down. And the mouth is the dirtiest space in the human body. So whether he's eating or not, all that saliva is still going to be going down that hole. So, you know, for sure he's proximal diversion. It's proven that source control has not been achieved here.
Okay. Dr. Dimitriadis, any comment?
I agree with Said as proximal diversion, esophagostomy, and at this stage, I need to go into the right chest and do whatever is needed.
Okay. Tariq, what did you do here?
Actually, to put a drain on the right chest, which I tried. If you want to treat or to put a drain in chest after he did first decortication, the adhesion was very aggressive there. Even the ribs was stick to each other. You cannot put a chest tube inside it. So the patient intubated, sent to ICU, which he was also very bad in condition. Even the ICU, the saturation would not came above 70 and 100% oxygen. So after that, they consult me. What shall we do? Unfortunately, I take him again to the OR, and I tried to drain the abscess under revision, which was very, very horrible procedure. His upper lobe was destroyed completely, and it was open to the chest cavity, draining, discharging amorphous amount of pus. At that time, I decided to do an upper lobectomy, which I did, and there is some picture below there if they want to show them the upper lobe. And the patient sent back to the ICU, intubated. The situation much better after that, but he's still in a very critical condition. The original source of sepsis didn't resolve until now.
Okay, Riyadh, what do you think about taking him back with this situation to the OR for a lobectomy or upper lobectomy?
Yeah, I can't say because the situation is bad, and he like Tariq, he's trying just to control the consequences of the source. Like there's still till now there's no control for the leaking or the source of infection. So I think even if we do this, the process of infection and the leak will continue. So that was just to try to control some sort of sepsis, but I don't think that will help a lot.
Okay, Dr. Dimitriadis.
Yeah, I agree with Riyad. And did at any stage do any esophagogram to see the exact location and the size of the esophageal leak?
So he did. He mentioned the CT scan done in the first operation that was 1 month ago. C8T1, that was the injury. Is that right, Tariq?
Complete cut of the cereals.
Complete.
Yes, between levels C8 and T1, complete cut. Yeah. Now the shrubness penetrating from both sides, inlet and outlet from the esophagus, was nearly completely cut.
Wow.
Now we don't have esophagogram in Gaza.
Yeah. So he's still in the ICU and it's critically ill.
CT and he's very, very, very critical condition. Yeah,
I
I don't
think
think he will
I think
survive.
we can wrap up this case. That I would strongly advise you, and a lot of other panels would advise you. You need to have esophagostomy, in the neck, cervical esophagostomy. That was what's needed to be done, and you have to have a help of a general surgeon just to move the esophagus into the neck. I think that's the only thing that you can do right now. Any other comment, Riyad, Zaid, or Dr. Dimitriadis?
No, I agree.
Yeah, I
Yeah.
think
Yeah.
continue, Riyad. Yeah.
I just agree with the diversion, and then we can, with the help of general surgery, put gastrostomy, jejunostomy tube,
You
maybe
already
gastrostomy.
had gastrostomy tube, Riyad.
I
Yeah.
know, but gastrostomy, when you have diversion, we prefer jejunostomy.
Okay.
So if I choose before, and then I will put jejunostomy and gastrostomy just for venting the stomach if I did the diversion first.
Dr. Dimitriadis, is there any difference between gastrostomy and jejunostomy in this area, in this situation?
Yeah, two things. Number one, there is a risk of gastroesophageal reflux and leak. And secondly, very often you prefer to use the stomach as a pull-up. You can use the colon, but a lot of people, including myself, like pulling the stomach up into the chest and do the definitive reconstruction.
Okay.
But the esophagostomy, of course, is very difficult. I would do it through a left sternocleidomastoid incision, sternocleidomastoid incision. In front of the left sternocleidomastoid muscle, you do the incision, and you find the esophagus. It's not extremely difficult.
Okay. Zaid, any comment before we move to the next cases?
Yeah, I agree. I mean, it's very the neck incision is not that difficult. It's all you have to do is along the sternocleidomastoid, you have to get the omohyoid muscle because that's the key to the esophagus. If you can't get that out, it's hard to deliver the esophagus out. And then you just feel with your finger, you feel where the trachea is, and we know that the esophagus is behind the trachea. And in an ideal setting, you know that in the TE groove there's the recurrent laryngeal nerve, so you want to make sure that you don't visualize this. There's a trick where you grab the larynx with your hand and turn it leftwards. That will bring up your esophagus. Plus, if you just pass an OG tube in the OR or any kind of tube, even a Foley catheter, and just you can feel where that is and bring that up into the neck. So this patient, the biggest problem is they never had source control, so they developed this smoldering kind of infection. Right? They're teetering along, like Riyad said earlier. They're young, so they can hide it a little bit. They have drains, so it's not causing overt sepsis immediately. So they just teeter along until their immune system just breaks down.
Okay.
So source control, the most important principle is source control.
Dr. Dimitriadis, we have a comment from our colleague Samer. He's also a thoracic surgeon in Jordan. He said when you do a diversion, you should stable the GE junction as well. Have you any experience stabling the GE junction when you do diversion?
No, I do not stable the gastroesophageal junction.
No, you shouldn't do that. I would not do that. That would end up with a giant mucocele.
Okay.
Do not staple the. You have one problem. You don't need to make two problems. You want to remember why you're there. You need to fix the problem and leave as soon as possible. You do the minimal approach. There's no reason to add another staple line in the abdomen that in somebody who's severely malnourished now is going to start leaking, and you have an extreme problem. So no, there's no need, absolutely no need.
Okay.
To staple the GE junction.
Thank you, Tariq. I hope that was helpful for you. Riyad, do you want to start sharing? Go ahead. Tariq,
now, even before war start in Gaza. Here in Gaza, we don't have anyone who can handle the esophagus, and this is the problem in Gaza. Now, every case of esophageal injury was before war, or esophageal tumor was referred outside Palestine. Here, no one can handle it, and no one will interfere with the esophageal injury. This is the problem. From the first, I told all the consultants that this patient need a diversion. No one will do that inside Gaza, and this is the problem. No one have the specialty or have any courage to handle the esophagus.
Okay, so I think this is a great, basically, call for Riyad and Zaid and other thoracic surgeons with us. Maybe we can, once the war stops, we can sponsor Tariq for a fellowship in thoracic surgery where he had more training dealing with the esophagus and dealing with this complex esophageal situations. So Tariq, hopefully this war will end soon, and hopefully we'll sponsor you somewhere where you have to basically, get an advanced thoracic surgery fellowship. This is a call for Zaid at Mayo Clinic, for Tariq for Riyadh at King Hussein Cancer Center, and for anybody who wants to help Tariq, hopefully down the road for a full fellowship.
Sure,
Thank you,
sure.
Tariq.
Thank you, Osama. Yeah.
Yeah.
We are
Thank you very
working
much.
on that because they
that?
are in need. Yeah, we are working on that. So we
Great.
are in need. Yeah, they are in need. Especially esophageal stuff. It needs a very special, set of skills, and the environment should be suitable for the esophageal stuff. So yeah, you need a good training in that. You need a good bulk of cases.
Riyadh, do you want to start sharing your screen, please?
So actually, I have just few pictures just
Okay.
to present some of the work on the kids. So I will. So Tariq, can you stop sharing, please?
I did. I did stop sharing. Okay, you can share now, Riyadh.
Sure, I'm working on that. So, can you see the picture now?
Yes, but you have to make it bigger so we can see them.
I'm trying to, my skills in the Zoom is
It's double.
obviously very. Okay.
Dr. Dimitriadis, you want to comment? You have your hand up.
Just, I wanted to say that this is an extremely difficult case, even in the best equipped hospital in the United States. And I want to compliment the team for doing what they did. But at this stage, having in mind the condition of the patient and the limited resources, I think it would be advisable to discuss with the family to make him come for care. I do not see any light at the end of the tunnel.
Tariq, what do you think about discussing with the family comfort care in Gaza that, well, we can't do anything anymore and he most likely is going to die? Would they be acceptable for such thing?
Actually, this is the problem. His family is in the south. He's the only one here in north. Now, I contacted them and I told them about the situation, and I arranged even a referral for him to outside Gaza. I wrote the paper and we arranged everything, but unfortunately,
But just let's just make
this
it
process
clear.
takes very.
But just let's make it clear, transferring patients from North Gaza to South Gaza is just a hell of a problem. And they just allowed only few pediatric cancer cases to be transferred over the last maybe 6 or 7 pediatric cancer cases to be transferred from the north to the south. And then the other problem is from the south to outside, it's also a huge problem. As we speak, according to the WHO, there's 12,000 patients need immediate referral to outside of Gaza for treatment, either war-related injuries or patients with cancers or any chronic diseases, any cardiac problems. The problem with this, referral and transfer is a huge issue. And we discussed this issue when we did the hepatobiliary injury about the 9-year-old with the 2-millimeter bile duct that had bile duct injury, and she leaked for a long time until eventually she healed. But Riyadh, is your presentations ready or not? Okay, Riyadh. We can't hear you, Riyadh.
So actually, I have some few pictures.
Okay.
Just to mention and to thank Tariq and to thank all the thoracic surgeons there. Actually, in my stay there were like almost 3 to 4 urgent thoracic cases almost every day. You have the acute injuries, you have the shrapnels that need to be removed because of the hemothorax, pleural effusion, some complicated shrapnels, and they have the some of cancer cases that need to be done. So every day you have a lot of thoracic cases, and this is one of the kids that was injured by a bullet, and there was like a shrapnel in her lungs, and it was causing her recurrent infections. So we needed to remove it. She is only 2 years old.
So the bullet had exploded inside her
Yeah.
chest. That's what you mean?
So yeah.
Okay. Do you have any imaging for the bullet?
So can you see this now, or
No, we can't see.
okay,
You
sure.
have
So,
your
okay.
share your screen.
Can you see it now?
Okay, yeah. This bullet, you got it out of the patient lung parenchyma.
Yeah. So it was in the left lower lobe. I
Okay.
did it with VATS. So I did small wedge resection. I felt it. It's like, a small nodule in the lung. And then I took it out with the staplers. The
Okay.
patient did well, and she discharged home next day. And I asked her about her like a few days ago, and she was doing fine.
So I believe this is maybe shrapnels from a rocket rather than a bullet.
Yeah,
It's a bullet.
yeah. No, I agree. Yeah.
Yeah,
Sure.
this is shrapnels from
Yeah.
a exploded rocket.
Yeah, sure. We
Okay.
have a similar case with a bullet.
Yeah.
And then you see this every day with acute injuries, with the chronic injuries, with the injuries that shrapnel is causing a lot of complications. And sometimes just knowing, because they know that they have some foreign body inside their body. Some
Okay.
patients, they just kept asking and just to remove it.
Okay.
And then the consequences of infection, the consequences of hemothorax. Sometimes I just went there and evacuated it with VATS just to avoid, empyema and frozen thorax or something like this. So there was a lot of empyema, decortication, drainage, hemothorax drainage.
So Dr. Dimitriadis, sorry. Dr. Dimitriadis, what do you think about going after foreign bodies from war-related injuries? Is something we should do, like this case, for example, a lung parenchyma, sometimes in the soft tissues, when you should go after the foreign body in war-related injuries?
That's a very good question. If the bullet fragment is fairly superficial, you can feel it and you can remove it without any risk, I think you should do it. But if the patient has a bullet which is asymptomatic anywhere in the chest or retroperitoneum or soft tissues, I will not remove it at this stage if it's too difficult, too complicated, especially with limited surgical resources and materials.
Okay.
However, in young kids with retained bullets, I would recommend that in the long term, you monitor lead levels.
Very nice.
And some of these kids will develop lead poisoning. And at least in Los Angeles, we monitor lead levels on a regular basis for people with retained bullets. And characteristically, a few months ago, I had a young man with 2 bullets, retained bullets, one in the retroperitoneum and the other one deep in the thigh. And he did not need an operation. But before discharging, we did lead levels, which were very normal.
Okay.
4 weeks later, he came back to the outpatients. We repeated the lead levels and they were sky high.
Mm-hmm.
We took him to the OR, we removed the bullets and the lead levels came back to normal. Okay. So I would suggest that in Gaza, in a few months from now or a few years from now, when things stabilize, especially in young kids, monitor the lead levels. Thank you.
Okay, it's kind of interesting. I can tell you in Gaza, they don't have even kits to do CBC and kidney functions because they're not allowed to get into these, materials for blood laboratory works. But that's something I think it's very important for people who are hearing us from Gaza. Because when I was there, they were like, I had almost daily 15 to 20 people just stopping me, telling me, well, can you feel this, sir? I have this bullet or I had this shrapnels. Can you take it out for me? Again, we're reserving the operating rooms for critical injuries. But I think that's something we should think about down the road is that basically these people should be monitored for lead poisoning or any other poisoning. Because again, these things stays in there forever. And I don't think the surgical workforce right now can handle such large number of extracting shrapnels, even in kids. What do you think, Riyadh?
I totally agree. Yeah, I think there will be more work after war for these patients, just to, you know,
Okay, can you go
treat
to
what.
the next case, Riyadh, please, for the sake of time?
Sure. So yeah, so just what it was, and I just like the other part of the, it's like not the trauma injuries, but it is the tumor.
Okay,
And this is a small kid with hygroma. It's invading the part of the neck, and we thought that it was extending into the apex of the chest.
okay.
So I went in with luckily I had the head and neck surgeons. Dr. Fadi Alauni was his expert in neck. So we went
He was
in.
visiting with you from Jordan.
Yes, yeah.
Yeah.
So luckily we have both specialty. And then we took this 2-year-old baby to the operating room, and then we operated on this hygroma, and luckily it was like almost capsulated, so
Okay.
we could remove it in one piece, and it was successful surgery. The patient went home next day, and there's a lot of cold tumor cases there that need to be managed, and there's no head and neck surgeon there.
Okay.
There's no oncological surgery there, surgical oncology surgeon there. So I think this part is missing, and this not the part need to be worked on
Okay.
afterwards. And this is the tumor. Can you see the tumor?
We're missing your no more images, only the little girl. Okay.
Now?
Yes, this is the tumor.
Okay, so this is the tumor.
Okay.
And then, so yeah, these oncological cases, there's a lot of these cases, and I'm sure you faced this, Osama, when you were
Yes.
there, right?
Well, I have a few other thoracic injuries that I would like to also present myself. So this is a 56-year-old male. To be honest with you, we were rotating in the morning, and this patient was in the recovery room, and the night team had operated for a splenectomy on him, and he had this chest wound they were just covering, and when we were rounding, this is what we found.
Video.
So, Dr. Dimitriadis, what do you think about this injury? This was penetrating shrapnels from the diaphragm. They did a splenectomy for him, and this is what we found. What do you think?
So the wound is in the chest?
Yeah, in the left lower chest, posterior.
Right, not the left.
This is a splenectomy patient. Yes, left.
Or the left. So the wound was on the left.
Yes, left lower chest posteriorly.
Yeah. Yeah. So I would do the debridement, put a chest tube and close probably with a vac instead of closing the skin.
So this is a sucking chest wound, as for the trainees to learn. It was, for me, it was the first time I've seen such thing. So we took him to the operating room, and we found also, instead of diaphragmatic injury that was not properly repaired, and we ended up doing also, he has a lung injury. We did a stable lung injury. It was back in February 2024. So Riyadh and Zaid, what do you think about, let's start with Zaid. What do you think about this injury? Have you seen a sucking chest wound like this before?
Yeah, I mean, we see sucking chest wounds just by virtue of our specialty. So this wound was the same wound that they did the splenectomy from?
No, he had a laparotomy.
Oh, this is separate. Okay, because I thought that was strange. Yeah, so it needs to be debrided and then the defect closed and put a chest tube in, because otherwise, you have a connection with the atmosphere. So this patient will not, they will always have a pneumothorax technically, and that lung over time will develop a rind, and then it will stay small, and then you'll have a space that you have to deal with, and the space will get infected. So you have to manage this.
How about if you see a lung injury, would you just resect it or just leave it?
If I see a lung injury and it's very easy to, manage, I will just, fire a stapler across it.
Riyadh?
Yeah, I agree, because it's not like an acute or a new lung injury. I think stapling is good option. But just I want to ask you, it's like, did you open between the ribs, right?
Yes.
Then the diaphragm was already open?
Yes, it was already open.
Okay, okay. So you repaired the diaphragm.
That was
No
my
mechanism.
question for another question for Dr. Dimitriadis. Would you think better to repair the diaphragm from the abdomen in this location or from the chest?
You are already in the chest. So you might have to extend a little bit the wound and repair it through the chest. I wouldn't go back through the abdomen again.
Okay. Yeah, this is
And
what
I
we
think
did,
most
actually.
thoracic surgeons chronically down the road will go through the chest to repair a diaphragmatic hernia. Was it any hernia or just a diaphragmatic hole?
Okay. Actually, it was they did a splenectomy for him. They did laparotomy and they did splenectomy, and they attempted to repair the diaphragm from the abdomen, which when we got from here, from the chest, we found the repair of the diaphragm is actually broken. So we had to do it again through the chest. But knowing that there was no spleen there, that kind of really helped us a little bit. But again, this patient, we did very well. To be honest with you, it was me and another general surgeon. We are general surgeons that we had to also do some, flaps trying to get these muscles back together. But this patient did well. This is another case. This is the patient presented with an explosive injury. You can see all this, viscera penetrating from a thoraco-abdominal, injury. So you see, this is the colon coming out from the left lower chest laterally, or thoraco-abdominal injuries. So what do you think, Dr. Dimitriadis?
What were the intra-abdominal injuries? It was exploratory laparotomy. What were the injuries?
So this is the injuries. We have the colon with the stool coming out of the left lower chest from this large penetrating injury.
Yeah.
So took him, as you can see, we did a laparotomy. He had the splenic flexure and the left colon is completely, emasculated. There are just extensive injuries. So we did a left hemicolectomy, as you can see right there, that we're taking. This is these staplers and ligatures. We got them with us when we got into Rafah. That was back in February. And then after doing this injury, our attention came to the thoracic part. Basically, his ribs were destroyed, his diaphragm was destroyed, and the muscles there's a significant soft tissue damage there. Any tricks, Riyadh and Zaid, how to close these complex injuries? Soft tissue.
So was there like a CT scan before to see if we have collection in the chest? No.
No. The chest was open when we got this back. His diaphragm and chest was open.
Maybe I will open like the thoraco-abdominal incision just to expose both at the same time to make sure that we control the, as you said, you did already left hemicolectomy, and then I can see the diaphragm from both sides and make sure that there's no lung injury. Drain the chest cavity, as I expect there was like a stool or dirty fluid inside the chest, so I need to make sure that we drain it very well and we wash until we get the area clean or almost clean. And then the diaphragm, I will assess how much loss I have in the diaphragm. So I need to repair it primarily. I will avoid any prosthetic materials if I have any, and contaminated or dirty. But the diaphragm is big enough, so we usually can repair it primarily.
So, Dr. Dimitriadis, what do you think about big thoraco-abdominal incisions for emergency situations? Would you be able to access all abdominal quadrants in emergency laparotomy with this left thoraco-abdominal incision?
So the priority is the abdomen. When you have thoracoabdominal injuries, the abdomen is the way to go unless there is a strong indication to go into the chest, severe bleeding, for example. The lung usually stops bleeding on its own for two reasons. Number one is a low pressure system. And number two has a lot of tissue thromboplastin, so there is hemostasis. It's rarely that you have to go in the chest to do a lung resection for a lung laceration. It heals very well. So, and go through the abdomen. At laparotomy, did you see any diaphragmatic injury?
Yes, actually, you can see we're taking the spleen out right here. This is the spleen, the diaphragm, the ribs, the soft tissue. We have this really, extensive, and the colon. So we
Okay.
did a laparotomy, and you can see we have both laparotomy here and also
Yeah.
a left, trying to do the debridement and the thoraco-abdominal injuries.
Right. I think through the diaphragm, I
Yes.
would suck out any bleeding and wash out the left pleural cavity.
Yeah.
And as you had a little bit earlier, you never need to put a mesh at the acute stage. It's not a good idea.
Yeah.
The diaphragm is very redundant, so you can easily approximate and do primary closure. So I put the chest tube, wash out the pleural cavity, chest tube, repair of the diaphragm.
Okay. Okay. Dr. Metex, you want to comment about such injuries?
During the Second World War, there was a lot of thoraco-abdominal incisions. Early in my career, I became very disenamored. I had a lot of complications from thoraco-abdominal incisions, so I stopped doing them entirely. I don't like thoraco-abdominal incisions, except for a thoraco-abdominal aneurysm that is totally elective. For trauma, I would do what Dr. Dimitriadis does. If I had a lot of stool and food in the left chest, I would take care of the abdominal injuries and close the diaphragm. And in rare cases, I would open the chest mainly to give the pleural cavity a bath. So I would wash out the left chest entirely, and I would not do any resection of the lung. But I would not use any prosthetic in the diaphragm. But the abdominal approach is the best way to go. Take care of everything that's in the abdomen, and leave a chest tube in, maybe two chest tubes in the left side.
Dr. Dimitriadis?
Yeah, just for information, Dr. Matok's group and also my group in Los Angeles published some work on these thoracoabdominal injuries, penetrating thoracoabdominal injuries. And the message is the abdomen is the way to go.
Okay.
This is where you are going to find the big repairable injuries. The thoracic contents rarely need an operation, unless, of course, it's a vessel or a heart or a higher vessel.
Okay. So, we have...
My understanding is the chest is already open. That's why because you said the reps was already destructed.
Yes.
The diaphragm was already open. So we have the chest already open. That's why I mentioned that.
But Riyad, my argument is, and we are argument as a general surgeon, that if you want to access the whole quadrant properly and safely in the abdomen during an emergency laparotomy, I think a midline laparotomy always our way to go. That's my way of learning, or the way that I was taught about laparotomies. Yeah. It's very difficult to throw a thoraco-abdominal to reach the pelvis, the right lower quadrant, the liver if you had the liver injuries. So that's at least my thinking of doing a laparotomy and then coming back to this incision. What I had a problem here closing the soft tissue damage, and we did these flaps and trying to get these things back together. Patient actually went out of the surgery intubated, and unfortunately, this patient did not make it, unfortunately. I have another case to present, kind of interesting case. Okay, so this is a young male, 29-year-old, who presented from explosive injuries. At that time, he had a decreased air entry in the chest, and they just went ahead, no x-rays available to kind of mass casualties. So they went ahead and inserted a left chest tube for him. And patient stabilized after the chest tube insertion. They admitted him to the hospital. I was not there yet. And they called me 5 days into admission that the food is coming out of the chest tube. So Dr. Dimitriadis, would you know anything else about this patient? Started getting septic, fever, chills, tachypneic, but that's what 5 days into it. No ICU, no CT scan available. At that time, X-ray was available. And I want to hear what do you think when you hear about such presentation?
Well, now it's 5 days later. There is nothing definitive you can do. It's damage control.
So what's coming to your mind 5 days later? Left chest tube, blast injuries, explosive injuries, and basically food coming out of the chest.
Yeah, you worry that there is an esophageal injury. That's a number one. I think number two, it could be an injury to the diaphragm and stomach. It's the GI. And at this stage, it's too late to do any definitive things.
Okay, Dr. Riyad, what do you think? What comes to your mind when you hear about 5 days later, this patient has food coming out of his chest tube?
Agree with everyone. You just need damage control, draining, and then.
So what comes to your mind? Esophageal injury? What comes to your mind?
Yeah, I think so. Sure.
Yeah. Dr. Maddox?
I have 2 or 3 comments. Number one, the study you're showing us right now is an esophagogram. Did you use barium or did you use gastrographin?
So we used gastrographin, the one that they use for CT scan. So the same one that they used for CT scan without dilution.
Do not ever use gastrographin in evaluating the esophagus. We learned that the hard way. If I think there's esophageal injury, I go straight to barium, the first case. I don't use gastrographin and then follow with barium. Barium is well tolerated in the
chest
bronchus. Gastrographin can cause a fierce bronchitis and pneumonia, so I don't use it. I still look at this and I don't know if it's a hole in the stomach or a hole in the esophagus. It makes a big difference on what I do.
Okay, so just to confirm, this is not an esophagus.
I refer everyone.
This is just asking the patient to drink contrast and getting a still images. It's not a fluoro where you can see dynamics. So we asked him to drink contrast and we got some X-ray just to see what's happening. No CT scan was available at that time.
I still don't know where I see dye in the chest. I don't know if it's in the stomach. I don't know if it's in the pleura.
Exactly.
But I refer everyone for historical purposes to William Beaumont. William Beaumont had a patient with the exact same problem with food coming out of the left chest wound, and his patient's name was Alexis St. Martin. William Beaumont spent his entire career studying gastric content from that wound. He did not repair it. And I don't know if he ever operated on another patient, but became very famous. I would open the belly, and just like the last case, I would fix what's wrong through a belly incision, and then wash out the pleural space, close the diaphragm, unless it was an esophageal injury, and then I would have source control, much like we had on the first case. This is 5 days later. I would not close that initial incision in the esophagus.
Okay, Dr. Dimitriadis.
It could be, as I mentioned earlier, either an esophageal injury or a gastric injury, and diaphragmatic injury with injury to the fundus of the stomach.
Okay.
How was the abdominal examination?
It was, abdomen was very soft, no abdominal, signs at all.
Yeah, it could be a diaphragmatic hernia with stomach going up into the left pleural cavity.
So our thinking at that time, as most people would think, is esophageal injury. So we tried to prove it through an esophagogram. That's what we had at that time, only X-ray still images while the patient is drinking after he's drinking the contrast. So we talked to the thoracic surgery team at that time. He was in another hospital. He could not come. He said the only thing I would do, just do a gastrostomy tube and properly drain the chest. So it's not my team, it's the other team took him to the operating room. And once they opened the abdomen, they called me, said, well, we can't find his stomach. And basically I come in and I see, as what you guys have mentioned, based on your years of experience, it's a diaphragmatic injury from this explosive injury with stomach being into the chest. And we think that actually the chest tube insertion had injured the stomach, to be honest with you. We think this is stomach in the chest, and the chest tube insertion, maybe it's the one that caused the injury of the stomach. We pulled the stomach back into the abdomen. It was very difficult, adhesed, infected. And we did a sleeve gastrectomy on this patient, trying along the greater curvature where most of the injuries are there. As you can see here, this is the sleeve stomach after stabling it. Again, these staplers we brought with us when we were going through Rafah. And right now, there's no staplers available in Gaza at all. And the sad story about this patient is that the patient who had an explosive injury had decreased air entry during the wartime. On examination حطوا له chest tube. بعد ما حطوا chest tube تفاجئوا انه المريض لما ياكل بيطلع لكن chest tube. What happened? This patient had actually a very large paraesophageal hernia. The chest tube went inside the stomach. The stomach, as you can see, is quite open. Okay? So the sad thing about this patient, we did this nice surgery, we finished at 4 in the morning, and he had no family to take care of him, because typically there's no ICU beds. Basically, the floors are full. So we send him with the nursing staff to the floor. And since the nursing staff were overwhelmed, this patient, again, straightforward, simple surgery, repairing the diaphragm, actually due to basically poor nursing care, they were overwhelmed. They could not catch up with all these injuries. This patient died 2 days later. No antibiotics was given, no fluids, nothing. So it was a sad story that was such great surgery. This patient died. Any comment here?
Yeah, actually,
that's really very sad. That's really very, very sad.
Okay. Riyad, want to comment?
Yeah, it's actually very interesting and very rare, and it's good catch actually to find the stomach. And as you mentioned, you did a great surgery, but was no post-op care. So yeah, it was very, very sad.
Yeah, and that's a common thing. I just want to read some comments from a medical student. He's thanking all the people who's trying to help the people of Gaza. We have Simon Fitzgerald. He was a trauma surgeon in New York. He was with us in one of the meeting. Simon said this is a very interesting thing about training people of Gaza to deal with complex cases down the road, so we can take this to a next level. Sumayya Baydin, she's I think thoracic surgery in training in the States. She says, Dr. Riyad, thank you for being with us. And there's a question about doing a T-tube for the esophagus for esophageal injury. What's your experience, Dr. Dimitriadis, in using T-tubes?
Yes, we have done it. I have done it a few times in cases with very neglected, delayed diagnosis of diaphragmatic perforations. Mm-hmm. You do the thoracotomy and you find an injury to the esophagus. And the tissues are really very bad quality. You cannot repair it. In these conditions, we have done a T-tube. You need to bring out the T-tube as close to the esophagus paraspinally, as close as possible. Yes, we have done it. Very often they leak around the T-tube, but you have a drain. You have a chest drain, so we have done it. It's not my first option. It's a damage control option. Thank you.
Dr. Riyad, about using T-tubes for esophageal injury?
I don't think it's appropriate to use it actually. I don't
Okay.
know, but yeah, I never use it. I never saw it.
Okay, Dr. Matex, you want to comment here?
Yes, I used to use it. The trouble is because surgeons do not do common deck explorations anymore, the company making the T-tubes stopped making them. So I cannot even get a small T-tube. They're not available. So if it's been neglected, like a Boerhaaver's for several days, I would maybe put in 2 tubes, one in the esophagus going up and through the hole going down into the stomach for drainage and feeding purposes. But T-tubes have been written about, but you cannot buy them because they don't make them anymore.
Well, thank you very much again, everyone. Dr. Matex, Dr. Dimitriadis, Riyad, Zaid, and Tariq. Again, this is what we try to do and help the people of Gaza, trying to make this more of an interesting and educational events. Again, all these webinars are recorded and you can have it on Dr. Osama Hamid YouTube channel. Hopefully in 2 weeks, we're thinking about major vascular injuries. We're preparing some cases for major vascular injuries we encountered, and we can learn more about these injuries. Dr. Dimitriadis, any comment before we finish?
I think that these were some dramatic cases, operations done extremely suboptimal conditions, heroic efforts, and I commend the team, the medical and surgical team and nursing team for doing what they are doing.
Okay. Dr. Maddox, any final comment?
I ditto what Dr. Dimitriadis has said, and thank you for your leadership in bringing 100 people together on this Sunday with different times all over the world. Congratulations.
Thank you.
And hopefully, as this war ends, we'll find a way for these. You said 12,000 people need referral out of Gaza?
Yes, immediate, according to the WHO.
We need to communicate with the World Health Organization and say, how do we take care of this? What do we do?
Okay.
All right. Thank you very much.
Thank you. Thank you very much. Thanks, Tariq. Thanks, Riyad. Thank you very much. Bye.
Thank you. Have a great night. Bye.
Goodbye.